Okay, so clinical suspicion is now sky high based on all these systemic and physical clues. We've checked the eyes, the tongue, the tendons, the postural blood pressure. Now we move to the definitive tools.
Right. The diagnosis rests upon the combination of clinical findings, specific imaging patterns, and ultimately accurate protein typing.
What about the common cardiac blood markers we use to diagnose heart failure or heart attack?
The NT-proBNP, which is a marker of cardiac strain and stress, is generally significantly elevated. We're talking 1,000 to 2,000 pgml or even higher. And also, high-sensitivity troponin, a marker released when heart muscle is damaged, is frequently mildly but persistently elevated.
That is a critical combination because elevated BNP and mildly elevated troponin in an older patient, to many clinicians, that immediately screams heart attack or ischemic heart disease.
Exactly. This combination often leads to a dangerous misdiagnosis where the patient is treated for clogged arteries when the real issue is misfolded proteins, and the clinician wastes valuable months investigating ischemia while the amyloidosis just gets worse.
So high BNP and troponin in a non-ischemic patient should immediately trigger the thought of amyloid.
It should.
And the systemic labs can quickly tip us toward AL if they're positive, right?
Yes. Heavy proteinuria and associated hypoalbuminemia strongly suggests that the kidneys are involved, which is a key feature of AL but not TTR. If we see hepatic involvement in AL, the alkaline phosphatase level, a liver enzyme, may be significantly elevated.
Got it.
It's also worth noting that while AL is related to multiple myeloma, the sedimentation rate is usually normal or only minimally elevated in AL, unlike the marked elevation you often see in active myeloma.
Oh.
The ECG in CA can show abnormally low voltage. This means the electrical signal across the heart muscle is very weak. This is particularly classic in AL amyloidosis because the thick, non-conductive amyloid tissue effectively shorts out the electrical signal. Echo is extremely useful. It reveals classic structural findings. It shows dramatically increased left ventricular wall thickness without ventricular dilation.
And that's the crucial finding, a thick-walled heart that struggles to fill, which is so different from the dilated, thinned-out heart you see in classic systolic heart failure.
Exactly. You also frequently see biatrial enlargement. Diastolic function is severely abnormal, showing that classic restrictive filling pattern.
But the real diagnostic game changer in echo is the advanced analysis, specifically the strain pattern. I know you know what I'm talking about, but for the listener, what specific pattern should we be looking for?
Right, so we need to go beyond the traditional ejection fraction, which measures overall pumping strength and might be deceptively normal. We use longitudinal strain imaging, which measures the contraction of the heart muscle fibers in the longitudinal plane. The finding is so characteristic, it's called the bullseye clue.
Tell us what generates that bullseye visual.
Well, the pattern shows that the strain, the ability to shorten, is relatively preserved at the left ventricular apex, so the tip of the heart, but it is severely impaired at the base where the heart connects to the great vessels.
And when you color code that strain pattern in imaging,
it creates a characteristic bullseye appearance, a bright color representing preserved function at the apex, surrounded by duller, severely impaired tissue at the base. Yeah. This apical sparing is highly suggestive, it's bordering on pathognomonic, of cardiac amyloidosis.
And you can also see the atrial impairment on the echo, too.
Yes, that shows up as a very small, weak, a wave on the Doppler, which indicates the high risk of blood stagnation and thromboembolism.
Moving beyond echo, cardiac magnetic resonance, or CMR, provides even more pathological detail.
CMR is excellent because it helps us understand what is causing the thickening. It confirms the abnormally thick ventricle, but it adds two key pieces of information. First, specialized sequences can measure extracellular volume.
And amyloid infiltration would cause that to expand.
A marked expansion of the extracellular space because the amyloid is deposited outside the cells. This is a crucial distinction that separates amyloid infiltration from true muscular LV hypertrophy, where the cells themselves get thicker.
And the second major finding involves the use of contrast agent, gadolinium. This is considered almost definitive for CA.
Yes, the use of gadolinium contrast is the gold standard for defining the tissue damage. In cardiac amyloidosis, you see extensive transmural delayed gadolinium enhancement of the myocardium. That means the contrast agent, which is usually washed out quickly, stays trapped within the amyloid deposits for a much longer time.
And this causes a specific look on the images.
It does. It's associated with an abnormal nulling of the images, meaning the signal from the heart tissue is disrupted. This finding is considered a near pathognomonic feature of CA.
Now we get to the test that has truly revolutionized the diagnosis. because it specifically differentiates TTR from AL non-invasively. The nuclear imaging scan, often called a PYP scan.
This is the critical diagnostic tool of the modern era. Tracers originally developed for bone imaging, like technetium pyrophosphate or PYP, are not usually taken up by the normal heart or in other cardiac pathologies.
But with TTR.
But in patients with transthyretin amyloid cardiomyopathy, TTR, there is avid tracer uptake. The heart just lights up like a Christmas tree.
Why does TTR uptake these bone tracers, but AL usually doesn't? Is it the different chemical structure?
It is. It's the specific chemical properties and composition of the TTR deposits that attract these phosphate-based bone tracers. They bind strongly to the TTR fibril structure. The positive scan is graded based on intensity. You want to see marked myocardial uptake that's brighter than the ribs with an absence of blood pool uptake.
And this ability to light up TTR non-invasively is revolutionary because it can bypass the need for a biopsy.
It can, provided we are absolutely certain it's TTR.
And that leads us to the single most important caveat in amyloid diagnosis. The PYP scan sounds like a quick solution for TTR, but the source emphasizes we cannot skip ruling out AL even if the scan looks positive.
That is the absolute golden rule. Because AL amyloid cardiomyopathy may occasionally have low-level myocardial uptake of these bone tracers, it is critically important to immediately perform a full hematologic workup to rule out a plasma cell dyscrasia.
So you need to measure serum free light chains, serum and urine protein electrophoresis, and immunofixation.
You need the full panel, every time.
And if the nuclear scan is strongly positive for TTR, and all those plasma cell tests are perfectly clean,
then you're good. If all plasma cell dyscrasia lab tests are negative and the nuclear scan is strongly positive with supportive imaging, TTR amyloidosis can be confidently diagnosed non-invasively. This is a game changer because it allows treatment to start immediately.
But the sources warn about a complicating factor: monoclonal gammopathy of unknown significance, or MGUS. Can you explain what MGUS is and why it complicates the typing process?
MGUS is a common benign condition in the older population, where a small, non-cancerous clone of plasma cells exists and produces a monoclonal protein. It can coexist with TTR amyloidosis.
So the lab tests for plasma cell dyscrasia might show abnormalities due to the MGUS.
But those abnormalities may be entirely unrelated to the actual TTR-driven cardiac disease.
So if the labs are abnormal, even with a positive TTR scan, uncertainty remains. What happens next?
If light chain amyloidosis remains a possibility because of these labs, a consultation with a hematologist is mandatory to clarify the source of the protein. Sometimes, to be absolutely safe, a tissue biopsy is still required for definitive typing. The consequences of misdiagnosing AL are just too severe.
Which brings us to AL diagnosis. If TTR can be diagnosed non-invasively, AL still requires the traditional gold standard.
That's right. Unlike TTR cardiomyopathy, there is no definitive non-invasive test to diagnose AL amyloid cardiomyopathy. A tissue biopsy is always needed to confirm the presence of amyloid deposits and, critically, to identify the light chain protein.
Since AL is multisystemic, where do clinicians typically biopsy to avoid going directly into the heart?
Most AL patients have widespread systemic involvement, so a subcutaneous fat pad aspirate, a simple low-risk procedure, or a deep skin biopsy will show deposits in the majority of cases. This avoids the need for a direct cardiac procedure.
And if those external biopsies are negative, which sometimes happens,
then it is reasonable to proceed to an endomyocardial biopsy, taking a tiny sample from the inner lining of the heart. This will be positive in well over 90% of cases if cardiac disease is truly present.
And once we have tissue, how do we confirm the specific protein identity with absolute certainty? You mentioned mass spectrometry is preferable. Why is it better than the older method?
Appropriate typing of the amyloid should ideally be done by mass spectrometry, usually available via specialized centers. This is preferable over the older technique, immunohistochemistry, which uses antibodies to identify the protein.
And that can be inaccurate.
It can be fraught with diagnostic uncertainty because antibodies can cross-react or produce false negatives. Mass spectrometry, however, physically identifies the exact molecular weight and amino acid sequence of the protein. It gives you the definitive identity you need for the aggressive therapy required for AL.
And finally, regardless of the diagnosis, unless AL is confirmed, TTR gene sequencing should be done. Why is that mandatory?
Because we must rule out familial TTR amyloidosis. If a genetic mutation is present, it has obvious ramifications for the patient's siblings, their children, and potentially their grandchildren. It necessitates genetic counseling and screening for family members, putting them years ahead of the disease.
Once the diagnosis is confirmed and the amyloid type is identified, the treatment strategies diverge radically. Treatment has a dual focus: managing the mechanical manifestations of the heart disease, that stiff muscle, and stopping the production of the precursor protein.
Exactly. And managing the congestive heart failure is critical for quality of life. Because of that restrictive pathophysiology, patients are highly vulnerable to small changes in blood volume. They can't tolerate too much fluid or too little.
Which means
Sodium restriction is an integral part of management. By keeping the patient on a strict low-salt diet, it significantly improves their fluid balance and their response to diuretics. Diuretics are the mainstay of therapy, usually a combination of a loop diuretic like furosemide with an aldosterone antagonist like spironolactone.
But this is where standard heart failure dogma is completely overturned. Why are the typical life-extending heart failure drugs like ACE inhibitors, ARBs, and beta blockers generally avoided here?
This is a major area of required caution. AC inhibitors and ARBs are generally avoided, especially in AL. The key reason is the frequent presence of autonomic impairment, which makes the patient's blood pressure regulatory system fragile.
So these drugs can cause profound, dangerously low blood pressure.
They can. The benefit just does not outweigh the risk of a hemodynamic catastrophe.
And beta blockers, which slow the heart and reduce demand, are also problematic.
Beta blockade is also often problematic. Amyloidosis leads to a relatively fixed cardiac output. The heart can only pump so much blood because it can't expand enough to take more in. If you slow the heart rate down with a beta blocker, you further limit that output.
Leading to decreased exercise tolerance and worse symptoms.
Right. If a patient is seen while on them, the clinical recommendation is often to routinely taper and stop their use, as their sense of well-being frequently improves when they are off the medication.
So we need drugs that manage volume without dropping blood pressure or slowing the heart unnecessarily. What about the newest class of heart failure drugs?
The newest class, the SGLT2 inhibitors, appears clinically well-tolerated and quite valuable. These drugs were originally for diabetes, but have proven to have a massive benefit in heart failure. They work primarily by promoting a mild diuresis and having other cardioprotective effects.
And their benefit is across the board, which is unusual for heart failure drugs.
Yes, they have proven efficacy across the spectrum of heart failure, regardless of whether the ejection fraction is preserved, which is often the case in CA, or reduced. And they don't typically cause the profound hypertension that AC inhibitors do, making them a welcome addition.
Okay, let's talk arrhythmias and conduction issues. The stiff, poorly contracting atria are high-risk sites for blood stagnation,
They are. So the first step is addressing the high risk of thromboembolism.
meaning the risk of stroke is high.
Precisely. Anticoagulation in patients with atrial fibrillation or flutter is mandatory, regardless of standard stroke risk scores. This is a non-negotiable step. Crucially, available data suggests there's no increased risk of major bleeding, so we must prioritize clot prevention.
In terms of rhythm control, if standard rate-controlling agents are poorly tolerated, what is the preferred approach for AFib?
Restoration and maintenance of sinus rhythm is always preferred because the stiff heart just cannot tolerate losing that atrial kick. Amiodarone appears to be the most effective antiarrhythmic drug for this population, and a loading dose is ideally given prior to an elective electrical cardioversion.
What about advanced procedures like ablation?
Pulmonary venous isolation for AFib ablation is complex in amyloid patients. The amyloid infiltration causes scarring that makes the tissue difficult to ablate, leading to a higher recurrence rate. So ablation procedures are often limited to patients with simpler rhythms like atrial flutter or reserved for highly symptomatic refractory AFib.
And let's talk about pacing, specifically for TTR patients who seem to have a higher risk of electrical block.
TTR patients are at a high risk for developing high-degree atrioventricular block, a failure of the electrical signal to pass from the atria to the ventricles. This is usually preceded by signs like bifascicular block on the ECG.
So if a TTR patient has unexplained dizzy spells or syncope,
Pacing should be strongly considered, often preemptively.
and what specific type of pacing device is recommended in the setting of this stiff small cavity?
We generally recommend biventricular pacing. This is because standard right ventricular pacing can cause abnormalities of septal contraction that may actually decrease cardiac output in this setting. Biventricular pacing minimizes that negative mechanical effect.
And finally, implantable defibrillators or ICDs to prevent sudden cardiac death. Are they effective here?
Sudden cardiac death is more common in advanced AL, but it's often due to electromechanical dissociation, not a shockable rhythm. So unfortunately, prophylactic ICDs are generally ineffective in preventing it. Consideration for an ICD should be highly selective, limited only to patients who have had a prior resuscitated cardiac arrest or sustained ventricular tachycardia.
This is the critical juncture where the treatments diverge radically based on the amyloid type. Let's start with AL, the bone marrow-driven disease.
Since AL is a plasma cell disorder, the treatment goal is hematologic. You have to eliminate the abnormal plasma cells and stop the production of the faulty light chains. The most common modern regimen is an intensive combination of targeted chemotherapy and immunotherapy.
The regimen is complex. Daratumumab, bortezomib, cyclophosphamide, and dexamethasone. For the listener, what is the goal of that cascade of drugs?
The goal is to induce a rapid, deep hematologic remission to silence the cancerous bone marrow clone completely. It's a full assault on the bone marrow.
This intensity demands critical coordination.
Absolutely. It demands critical co-management between the cardiologist and the treating hematologist. For instance, the steroid, dexamethasone, is notorious for aggravating sodium retention and fluid overload.
So the cardiologist has to be ready to aggressively adjust the diuretic dose.
Or even reduce the dexamethasone dose to prevent acute heart failure episodes.
Are there drug-specific cardiac risks with this intensive therapy?
Yes. Bortezomib, a core agent, may cause acute reversible cardiac toxicity, and it may also aggravate the autonomic neuropathy that's already a feature of AL. Patients require rigorous cardiac monitoring.
And high-dose therapy, like stem cell transplantation, is also an option for some.
For select patients who meet strict fitness criteria, yes, but the procedure itself is high risk for cardiac patients, involving weeks of profound fluid retention and a high risk of arrhythmias. A rigorous pre-therapy cardiac evaluation is mandatory.
The ultimate measure of success, however, is not just survival. Does the heart actually get better?
Following successful treatment, defined as a sustained hematologic remission, the congestive heart failure often does improve. We can see an improvement in left ventricular longitudinal strain, meaning the muscle fibers are shortening better. The amyloid may not disappear, but stopping new deposition allows the heart to partially recover.
Okay, now, switching to TTR. Since TTR is primarily produced in the liver, the goal is not chemotherapy, but focused on reducing or stopping further amyloid deposition from the circulating protein.
And the therapeutic landscape here is modern and incredibly targeted. It's divided into two main conceptually different strategies: stabilizers and silencers.
Let's start with the stabilizers like tafamidis and acoramidis. Can you give us a clear analogy for how these work?
The TTR protein must exist in a four-part structure, a tetramer, to function properly. When it destabilizes, it breaks apart into unstable monomers, which then misfold. So if TTR is a four-legged table, the stabilizers are essentially molecular glue.
They hold it together.
They bind to the protein and keep that tetrameric structure stable, preventing it from breaking apart and forming new sticky fibrils.
And what's the clinical benefit of using this molecular glue?
They are effective at slowing disease progression and, crucially, may even halt progression among patients treated early. They are taken orally and are extremely well tolerated.
And the second approach is the silencers. If stabilizers are the glue, what are the silencers doing?
Silencers are a completely different class of drug using RNA interference technology. Instead of stabilizing the existing TTR, they target the messenger RNA that carries the instructions to make the protein in the liver. Drugs like eplontersen and vutrisiran significantly reduce the production of transthyretin.
So using our table analogy, stabilizers are gluing existing tables, but silencers are shutting down the table factory in the liver.
Exactly. Silencers stop the source. They are currently approved for familial amyloid polyneuropathy, but are completing trials for cardiomyopathy and are expected to become major players in cardiac care.
This means for TTR, we have highly targeted molecular interventions that completely change the long-term prognosis, moving it away from a progressive, inevitable decline. Thank you for joining us on this deep dive. We hope you feel thoroughly informed.